So I just want to start by asking, how many of you work in industry? And how many of you work in academics? And then how many of you work in the community? So, okay, this is great, because that's what I do. Okay, so I wanted to just give you a little bit of context about why I care about community oncology clinical trials. I was born in North Dakota, and my dad was a family practice doc for a very rural community. And when my aunt and my mom had breast cancer, it was not lost on me that it was very difficult for them to travel 2 hours to the destination where they received their chemotherapy and then back again, and just the hardship that that brings, let alone having access to clinical trials. So I ended up going to medical school and my internal medicine residency at UT Southwestern, and then I went on to MD Anderson for my fellowship, and those were really amazing research institutions where I learned a lot about clinical trials and the value of clinical trials. And then when I got my first job, I went to West Virginia to do a kind of pay back my loans thing in a more underserved area. But luckily, the place that I worked had a really great community clinical trials program, and I learned how to do clinical trials with normal patients in the community. And then I went on to Oklahoma, and now I'm back at UT Southwestern helping them build their community program in the DFW area and bringing the clinical trials from the Dallas campus into the rest of the clinics. So, as you know, the burden of cancer in the US is really incredibly high. This year, about 2 million people are going to be diagnosed with cancer, and about 600,000 people are going to die. And the community oncologists who are out there are doing the lion's share of work of taking care of these patients. About 80% of people get their cancer treatment in local communities, and only about 15 to 20% of people journey or are able to get to an academic medical center. So I also wanted to show you where the NCI designated cancer centers are. You can see that there are like 1 million in the Northeast and a lot in California, but there's a lot of white space where there's not access to major medical centers that may be conducting the clinical trials. Now, community practices are everywhere. So this is one of the reasons why people get their care in the community, is because they're right down the street and they're very accessible. So why do we care about clinical trials, and why does this even matter? The reason that we have all of the new drugs that we have today are because people in your practice took part in clinical trials so that we could have these new drugs. Of course, we're looking at safety and efficacy and whether these drugs work better than the standard treatments that we have now. But I'm really interested in my patients not dying, and I want my patients to live longer. And I also want to find drugs that don't leave them with debilitating neuropathy or have better quality of life associated with them. So again, huge numbers of patients being diagnosed, 600,000 people are going to die. If you take that 2 million and you look at who actually lives in an area that they might have access to a clinical trial, it's about 500,000 people. But look how many people enroll. 25,000, if we're lucky, per year are getting onto clinical trials. And so there's this vast number of patients that are never contributing to our learning to make things better. So this untapped volume of patients, in adults, it's really around 5% of people that go on to clinical trials. This is such a missed opportunity. So the other thing that really bothers me, and I kind of learned this when I was in West Virginia, compared to the patients that I saw at MD Anderson, at that time, the life expectancy for lung cancer was 1 year. But all of my patients were dying in like 8 months or 9 months, and I was like, is it me? What's going on here? But it's really that the clinical trials enrollees are very, very selected patient populations. And you can see that if you've only got 2 to 4% of the adult population going on to clinical trials, is it really generalizable? Are the answers you're getting from these clinical trials, can you say that it works in women and people of color? You just don't have that information when everybody's white, wealthy, urban, and a man. So, there's problems here with how trials are conducted and not having enough access. So there's also an incredible social capital needed for patients to actually make it to a tertiary medical center to get onto a clinical trial. So my patients are often sick with side effects from their cancer and from the treatments that we've already given them. And some of them say to me, and I work in far north Dallas. The Dallas main campus is about 45 minutes to an hour depending on traffic. I have had patients choose hospice as their next option because they just can't wrap their brain around another hour of travel to do a clinical trial. You also have to have somebody in your life who can navigate the system to get you into one of these tertiary centers. You know, getting your path reports, getting the discs, getting through the rigmarole with insurance to get an actual appointment. And then who's gonna drive that patient? Who's gonna accompany that patient who might be like borderline wheelchair or using a walker? So there's a lot of pieces that have to fall into place for patients. And then, cancer is a financially devastating situation. They're already underwater with the bills. You go for a clinical trial and then you're hit with airfare, food, gas money. Maybe they're out of network and now your copay is much higher. Or if you're going for a clinical trial and your scans are 29 days old, you have to repeat them again, and that actually costs money. So these are all kinds of barriers. So the fact that we are only getting these kind of wealthy, white, urban men into our clinical trials, it just does not reflect the reality of the cancer patients that are being treated in the US. So if we have clinical trials in the community, then you get the average cancer patient onto the study, and the trial results are immediately relevant. And you also can answer your question very quickly, because if 80% of the patients are in the community, you're going to be able to accrue that trial and answer the question that you're seeking. So this is almost never talked about, but I'm going to talk about health system pressures to prevent referrals out of the system. We all know that cancer is big money. We all know that all of our patients go through tons of testing that generates ancillary revenue for our hospital systems. So they need CT scans, labs, immunotherapy, chemotherapy, radiation, surgeries. We make people very sick, and sometimes they end up in the hospital, and that is also profit for the hospital system. And I'm not going to mention names, but one of the community practices that I worked in used the EMR to kind of track outside referrals. And if I was sending too many patients to the university for a clinical trial or for surgery, or because that's where the best care was, not at my system, but at this other system, they would hold my bonus. So, if you have these kinds of pressures, why would you jump through the hoops to get somebody into a clinical trial? But if everybody had access to clinical trials, those pressures just disappear, and patients can have more options. So I wanted to also just talk to you about ways to get clinical trials into your communities. And the NCI has a couple of great systems, the NCORE and the cooperative group mechanism. So I don't know how many of you are familiar with the cooperative groups, SWOG, Alliance, ECOG, NRG. Sometimes you see those names up there when we're talking about clinical trials that I've read out. So these are usually academic groups of people that get together, and they want to answer questions that maybe pharma doesn't want to answer. Like, is this drug better than this drug? Or how do we sequence the drugs? Or how do we incorporate surgery? And so that they're trying to answer academic questions in a broad scale through the United States. And then this NCORE site participation is really, really important in getting these trials accomplished. So the NCORE is the National Community Oncology Research Program, and it has pushed clinical trials into the community at a very high level. They have 7 research bases and 46 community sites that are serving as kind of hubs. And then you've got this spoken wheel of smaller clinics that link to them, to where we almost have 1,000 clinics across the United States that are able to do research in the community. So here is a map of where the main hubs are. And I'm just going to show you, when I was working in Oklahoma, my NCORE was actually located in Missouri, and you can see that our NCORE had lots of little clinics scattered across 3 states, and we were able to access all of the cooperative group studies, which are about 200 studies. So it's a great resource. They put 30,000 patients on clinical trials within the last 4 years, and they have a 25% rate of enrollment of minorities, which is unheard of in industry trials or academic trials. So this is a really big bonus because we're capturing people that reflect the population of the United States. And then I love all of these places where you saw the white space, no access to universities. They're getting these places access to clinical trials through this mechanism. So if you happen to live in a state that doesn't have an NCORE like West Virginia, which is one of the other places that I worked, there is a way for you to align with SWOG or ECOG and become an affiliate member and have access to these trials. So for us, we lived in Charleston, and the West Virginia University in Morgantown had initially sponsored our affiliation. And then once we got enough patients that were routinely enrolling onto studies, we became our own site. But that's another opportunity if you don't have an NCORE nearby. So what I also find awesomely fascinating is that if you look at these cooperative group studies, over half, more than 50% of the accrual comes from the community. And so if we didn't have all of these 1,000 clinics contributing patients, it would be really hard for academia to get these studies finished. Another way to think about clinical trials and community practice is by joining one of the networks that has a really established network. So US Oncology is everywhere. They have about 500 practices across the United States. They put 88,000 people on trial over the last 2 decades, and I just find this wonderfully amazing. Texas Oncology, which is a subsidiary of the US Oncology Network, are right down the street from me, and I think it's really cool to see how we work together. In Texas, about 2,000 patients go on a trial with Texas Oncology. They have 6 phase 1 departments kind of scattered around the state. And one of the phase 1 clinics is right down the street from my clinic. And so when I have a patient that is running out of options, and my system, I could send them an hour downtown through traffic, or I could send them down the street to the Mary Crowley Cancer Research Center. And we share a lot of patients because it's much better for my patients to not have to do the travel. Sarah Cannon is also a private practice group that wanted to have access to research, and they have built an incredible network. You can see that they started in Nashville. They have both community practices and academic practice affiliations, and they do a lot of kind of early phase 1, first-in-human research. They're putting 3,000 people a year on clinical trials. That's another great network. And they seem very collaborative to where I think you could approach and say, how do we work together? And they'll try to figure it out. So if you live in a community where maybe you don't have access to clinical trials, but your university is nearby and you want to share patients, or if you are an academician and you have lots of community clinics around you and you want to get your research into the community, one way that worked really well when I was living in Oklahoma was I was welcomed to come to the OU tumor boards. And so every Tuesday I would jump in my car, run across, get to the tumor board, present my patients, get feedback on what kind of trials that they had. And then one of the lung doctors would come to my tumor board and be at our thoracic conference every week and tell us what studies he had open and give us advice. And it was just a very collaborative relationship, which, that's how it should be in the community. Another really cool thing that I got invited to do about 7 years ago was to be part of the clinical trial design in SWOG. And so one of the things, if you've ever put patients on trial, sometimes in the community, there are these extra steps that are often kind of correlative studies, not really endpoints of survival for the patient, but maybe they have to have an extra biopsy, or they have to come in for extra clinic visits that are a burden to the patient. If the community doctors are able to say, hey, if you make my patient do an extra biopsy every time, nobody's going to go on this study. You have an opportunity to kind of rethink and make it much more patient-friendly. So academic universities are now kind of catching on that all the patients are in the community and that you can't make the patients come to the main campus all the time because people just won't do it. Why would they? They've got great care right down the street. So a lot of academic universities are kind of starting these programs of getting into the community. And what's different about them? Not much. But if they offer clinical trials, that might be some leverage, to get people to come to your university community clinic. So in UT Southwestern, we have 3 clinics that are open at this time, and then we have 3 more on the horizon. And my clinic is kind of far north. We pull all the way from Oklahoma. It's great. It's been wonderful to be able to be a resource to them. So this is kind of how we've done in the last 6 years. The first 3 years, my partner was by himself, and the university really didn't want to give him anything more than kind of biomarker studies. Nothing that was, actually helpful to the patient as far as, treatment trials. I came in 2018. It was a pretty heavy lift, but part of my contract was I was not coming unless I was going to be able to do real clinical trials in the community. We had to kind of work out a mechanism to get drug out to the different clinics, to get the pharmacy set up. The first year, we put a lot of patients on study. Second year was COVID. Third year, we put 64 people on clinical trial, and our community clinic actually enrolls better than some of the disease-specific teams on the Dallas campus. And so in the last 6 years, we've put 216 people on trial that would never otherwise have that option. We've grown to be 4 physicians. We continue to grow. And then we have also figured out studies that work best for our population. So we now are principal investigators opening trials that matter to us and not so dependent on what the Dallas academic people want to do. We are still running into some problems with industry where the industry studies will not allow us to travel the drug up the road. And then there's this arbitrary, we don't allow satellites. That's a thing. And I'm like, well, that's really sad because we put 64 people on study, a lot more than they did. You should maybe give it to us. But it's a culture thing that I think is going to have to evolve. So some of our successes, the PRECOG trial, which is a cooperative group trial, we put 20% of the patients in the nation onto the study. And I never thought that I would get my name on a publication, but I did because of how much we contributed to it. We also decided to open a rare tumor trial because, we have these rare patients that walk through the door with weird histology that don't have an option. And when I opened this trial, MD Anderson started referring patients because they didn't have this study. And so I thought it was super crazy that MD Anderson is sending 6 patients to a tiny clinic in Dallas to receive a trial. But, it's awesome for the patient to have that option. My partner is a palliative care fellowship trained hem-onc doc, and she wanted to open a palliative care study, a supportive care study, and so she did an appetite cachexia study. And we have one industry trial that we're leading the nation in accrual because we have patients. We have a lot of patients, and we're in clinic every day. So take-home points, most of the patients are in the community. If we are able to get clinical trials into the community, you're going to accrue fast. You're going to be able to actually generalize the results. You're going to give your patients access to novel treatments that may actually help them live longer. And then if you are in a place where you have an academic institution that has clinical trials working together, partnering with tumor boards, being invited to give your perspective on the design of clinical trials is super important. And then if you want to make a connection and see if research can be brought into your practice, you can affiliate with the cooperative groups, or you can touch base with Sarah Cannon and see if they would be a subsidiary for you. So just lots of opportunity out there, and I'll close with that and take any questions.
Hi. I work in a public hospital in New York, and I run the Clinical Trial Center, so I agree with you that this work can be done in the community. One of the biggest barriers I have is language, and you didn't touch on that at all in terms of, getting the consent forms in a patient's language. Like even just a couple of weeks ago, pharmaceutical companies will do it, but only as the patient comes in, and then they end up having to wait a long time.
And who's going to do that? Like, who
I
wants
will.
to wait? Like, but
Well,
the patient may not.
The patient,
the patient may not.
Sometimes
yeah.
we actually bear the expense of that, and we're a public hospital, we can't afford it, but it's usually $2,000 to $6,000 per consent form.
Yeah.
And so how do you work around that? Like if you're really serious about giving access
So,
to clinical
yeah,
trials, I
think-
don't know how they could not do that.
I think you have to talk to your institutional review board. So we have a short form in any language where it can have kind of a very quick translation of the protocol synopsis, and they allow that to be a way to kind of get them going. But that's an institutional exception.
But they have to promise that we're getting the consent form later. So that's the issue. It's not just, it's a short
really
form
tricky,
and
it does just leave barriers for people who are not, English speaking.
Exactly. So, I just like to shout that out and let people know that, because it really is. Everyone's like, oh, we want minorities, but they really don't have a mechanism that's really effective for
people with other languages. Yeah.
And I just wanted to ask you, in terms of, I've been doing this for like 15 years, and I know I've had to pivot because of the targeted therapy, the molecular genetics study, like even though I can get 100 patients on study when it was like broad, especially in the cooperative groups, but now that everything is so targeted, it's become harder, and I think the academic partnerships are even more important because there's only a couple of patients that are going to be eligible for some of these,
Right.
So how have you worked around that more recently?
Honestly, we don't focus on the very narrow, like I do a lot of GU, FGFR is out there, but none of my patients have it. And so we pivot and we focus on things that are more broadly based, are going to affect more people. Like we have a prostate surgery versus radiation trial. We kind of look at our population and see what's going to work for them. And we don't spend a lot of resources on those niche things. Down in Dallas, they will accrue 100 people onto EGFR studies. I have 3 of those patients, that's it. So it's not a good trial for our community.
Yeah.
And then there was one question from online. It says, what can pharma do to better support placement of clinical trials in the community setting? So first of all, get it out of your brain that satellites and regional community practices are not capable. We're often the most capable because we're scrappy and we see patients all the time and we know how to read and follow protocols. So arbitrary rules need to be thrown out. And then this, like not being able to travel drug, not working with people, it's a culture thing that just needs to shift. Okay, thanks so much.
We actually have another question online that says, when the patients and family have to travel for clinical trials, what kind of assistance is available for that?
Almost none, almost nothing. And that's one of the reasons why people, sometimes that makes or breaks whether they live a little bit longer or have access to more treatment. We have a grant that just came through in Texas where they'll kind of defray gas money, hotel stay, but it's defray, not avoid. It's a small portion, and it's just not enough to really make a difference.
Thank you so much.